So I'd like to welcome you. Thank you so much, Dr. Sean Mulvaney, for being part of the Veterans Summit. I was first introduced to you through the 60 Minutes episode that you did on SGB, and I was just fascinated. And since then, I have asked everybody I know that's dealing with veterans or that's in the mental health field, do you know what SGB is? And I am surprised by how many are not familiar with it. So I am thrilled to have you explain this and let them know how incredibly effective this has been from all the work that you've done, which I understand is over 1,000 procedures.
It's actually approaching 1,600 at this point.
Oh my goodness, that's fantastic. And I understand also that the number is roughly 8 million people that are suffering from PTSD. So
By all accounts, that's the conservative number.
yeah, so this is really a dynamic breakthrough for those that are suffering. Can you sort of start from the top and explain how the procedure works? That I know that it's a shot in the neck. That's usually what I say. So you could start with that. That'd be great.
Sure. First off, I'd like to give just a little bit of background where this has, since for 10 years now, this has over 20 papers in the peer-reviewed medical literature, all showing safety. Of course, it takes a randomized clinical trial to show efficacy. We have a trial that was published in the Journal of the American Medical Association Psychiatry in November 2019. So we have an RCT level evidence. There's other RCTs, but then there's lots of other articles encompassing everything from, we just published an article in June of 2020 looking at doing a 2-level block. So doing the block at C6 and C4 and to see if we were getting additional benefit from that.
Right.
But essentially what's going on, what we have in post-traumatic stress disorder, post-traumatic stress injury, is a condition where the sympathetic nervous system gets kind of stuck in the on position. And it's very akin to the situation where you have a computer with the blue screen of death. And no, Bill Gates himself couldn't code his way through that. You have to, after talking to tech support for 45 minutes on hold, they're going to tell you to unplug it and plug it back in. And when you do that, it comes on at its baseline settings. It doesn't come on back locked up again. It comes back on at its normal settings. And although it sounds too simplistic, what we have seen happening over 10 years of researching and publishing on this is that when we take that element of the autonomic nervous system, the sympathetic nervous system, that fight or flight nervous system, which is literally becomes stuck in the on position, and through a stellate ganglion block, which is an injection of a long-acting local anesthetic precisely along the cervical sympathetic chain, usually on the right side, although we have some data on left-sided studies. And we turn off that conversation between the brain and the body. The first assumption people make is that the brain is in charge. It's not in charge. It's probably the senior voting member, but it is, that gut feeling is a real thing. That neural tissue in the body is a real thing. And what happens is it gets stuck in a loop where the brain is amping the body and the body is in turn amping the brain, because these are afferent and efferent conversations that are going on. The body is giving input to the brain and the brain is sending input to the body. When we reset this system, when we stop that conversation, now most people, overwhelmingly, it's on the right side of the body, just due to how the body is wired. It goes up and into the elements of the central autonomic network. People are familiar who do this with like the amygdala, but that is only one aspect. Insular cortex is another, prefrontal gyrus is another. All these conversations are going on that make up that sympathetic, that fight or flight response. They are allowed to, when they stop receiving input, they stop sending that input, and they're allowed to kind of re-baseline those. We hypothesize those neurotransmitters drop down to normal levels, and when they do, when the block wears off and that normal conversation returns, they are now at, everything's re-baselined. Both the body and the brain have re-baselined. And when it comes back on, it's no longer amped. It's now at baseline. And what we see is that these changes are durable. This isn't just for the moment. This isn't, And we follow up on people. Now our protocol is we follow up at 1 week. That 1 week marries up their improvement to the procedure, and it makes a causality that they didn't just get, if they've had it, especially for more than a year in most of our patients, that if they get better, then it seems to be due to the procedure, or we try to not make assumptions here. We follow up at 1 month, and that 1 month will, if they have significant improvements. Now we're using PCL5 now. Initially we used the PCLM. These are questionnaires. If you type them in, they'll come up on Google. They're single page questionnaires that have been validated to show change and improvement in anxiety symptoms of PTSD. We also use now the GAD-7 because for a lot of our, especially our non-military members, actually PCL5 is just for PTSD. The GAD-7 or Generalized Anxiety Disorder 7 questionnaire, another one, free, Google ability. A lot of times it will capture anxiety that the PCL5 doesn't capture. These are the instruments we're using because the gold standard is CAPS. The CAPS survey has to be, it takes about a half hour. It's administered by a behavioral health professional. And it's not always, you don't always have these people around. So we have to use these other validated instruments, these questionnaires to look for our change. What we see happening is that these changes are durable and they last. And we have some pre-publication data that says that we're now seeing, we'd see some people, we do a block and it looked like they should get better and they didn't get better. About 1 in 20 people, or about 4.5%, it appears from our initial data, that don't respond at all on the right side, but they respond on the left side. Now, this makes sense because we're all wired a little bit different. And this is such a complex wiring in the head that small changes can change how people respond. So, and we see like they don't respond to a right-sided block and they respond profoundly to a left-sided block. We don't, it has nothing to do with hand dominance. We can't really tell. Is that, am I capturing that a little bit?
Yes, absolutely perfect. One of the things that I had questioned is, well, what is actually the anesthetic that you're using? And in some of my research, it was saying this is a very safe anesthetic. It's used on pregnant women. So the drug itself, the side effects are nominal. Is that correct from this procedure?
Yeah, the drug that we use is ropivacaine. The trade name is Neuropen, and it is available in different strengths, and we use 0.5% as far as the strength of that we use. On a typical single level block at C6, we'll use between, on a smaller person, maybe 7, a larger person, maybe 9 milliliters of anesthetic injected precisely into a location, usually for those anatomists out there, into the ventral aspect of the longus colli, medial to longus capitis, and it's going to be dorsal to the great vessels of the internal jugular vein and the carotid. But also nestled between the carotid and the internal jugular vein is also the vagus nerve. Now, what I've started doing in practice, especially on cases that maybe don't respond as well as I'd want, is up to 12% of the sympathetic nervous system runs through the vagus. And in fact, an animal like the horse only has one autonomic trunk. All the parasympathetic and sympathetic responses run into it. We've always thought of the vagus nerve as being predominantly parasympathetic, but it turns out it also has sympathetic responses. So it's you can, with using, if you're skilled with ultrasound, you can precisely guide a very fine, a very thin gauge needle right next to the vagus nerve safely and slowly inject. Now, these are high skill procedures. You have to have the training and ability to do them, and also the training and ability to deal in the case of a rare but adverse event, especially adverse event if your skill wasn't quite so good. I have not had a single serious adverse event, but we're ready for one at all times. But by putting some local anesthetic near the vagus nerve, you capture those last bits of sympathetic. So we're constantly looking for, how do you do this better? And in all the papers that we've used, now some people use a different long-acting anesthetic called Marcaine. I don't use Marcaine. Marcaine is much more cardiotoxic in the event of inadvertent intravascular injection or uptake. Ropivacaine is safe, and we've had very good results with it. And it's just a long-acting anesthetic, a local anesthetic, like like lidocaine, people know, or
Right.
maybe colloquially they call it Novocaine at the dentist. It's a
Right.
numbing agent that stops nerve conduction, and that's all that we're doing.
And that itself is what's resetting. It's that
It's the turning off of the conduction that's
that turns
allowing
it off.
reset. Yeah, so
In a
in other
sense,
words,
yeah.
people feel after we do a block, now I don't want to spoil someone about to get a block, but invariably what we see first we look for a Horner syndrome. So when we do the block 5 minutes after, some people check their blocks 20 minutes later. I check them 5 minutes. If it's not good at 5 minutes, it's not going to be good. And we're looking for the pupil on the side of the block to get smaller, the eyelid to droop, and for the white part of the eye or the sclera to gets red. In some people, they won't get that scleral icterus, that redness in the sclera, but some people do. Another thing that happens is they'll get congestion in the right nostril, just the right nostril. That's not used in our scoring criteria. We do formally score and have published on a scoring criteria because we want to know, did they get a good, strong block? And many doctors don't score their blocks, so how do they know if they really had and I don't score my own blocks, somebody else does. So, because your tendency would be to say, oh, I did a good job, where actually my tendency is to call a block weak because I want my patients really to do well. So we score the block, but then usually sometime 10 minutes after the block, 20 minutes after the block, they report feeling very calm, very relaxed, sometimes profoundly so, sometimes right away. But it is not an effect of the local anesthetic that was injected. It's actually an effect of the anxiety being turned off. That feedback loop is stopped. And when it happens, it's actually very profound. There can be an emotional release associated with that for many of these people, that they have hope for the first time in a long time. The very first block I did, the comment from the gentleman on the table was, who had long-standing symptoms, in his case, since Desert Storm 1. I remember him saying, I haven't felt this good since high school. Like it was, and I didn't know what to expect. I had no experience with it. So I was like, whoa, something's going on here. You know? I've heard now that same sentiment echoed again and again and again. Like I didn't even know I was in there. In the case of, unfortunately, childhood trauma, they don't even know what normal feels like. And they're like, what is this?
Oh my gosh. The relief must be just extraordinary. If you're in that state of hyperarousal, hypervigilance, anxiety, not being able to sleep, to have that sense of calm must be feeling just exhilarating.
Well, it's profound. And in people with serious symptoms, it's one thing, it's very profound. But I consistently see people with PCL5 scores in the 70s. And at this point, I mean, I was a SEAL for 9 years, and then I was a physician in Army medicine for 22 years, besides training, all of it in special operations. So I'm used to seeing, soldiers, and it was, over a decade of direct combat or more.
Right.
And it took years before they would trust me to tell me what was going on. But once they did, we were like, hey, let's treat this. And we had very good success, in treating this. But now I see people, I've been retired now for 2 years. So I see people from like the Las Vegas shooting. I see victims of human trafficking or people that were held prisoner, childhood trauma, childhood abuse, sexual assault and abuse, which is so common. So I think that 8 million figure that you brought up earlier is very on the very low end of the trauma and the suboptimal lives that we're dealing with. And when we see it kind of stop. Now, honestly, what I see is 1/3 of the patients that I treat fall into the category of one and done. They just needed to be reset and they move on.
Right.
Some people will be re-triggered, or they're in a current situation that is a trigger to them. Could be a relationship. It could be they have to get on a crowded subway and people jostle against them and that re-triggers them.
Right.
And in that case, if they need a repeat treatment, I never know when someone will need a repeat treatment, but it's based on symptoms. It's based on how did they respond to the first one. And we have very good success at getting them out of that acute phase. And then if they need repeat treatments, having it be longer and longer between each treatment. And they may be well for years and re-trigger. And I have examples of that where with some of the combat medics I work with directly where they'd be fine. And then something, they would be re-triggered usually by hearing about another friend's experience or something like that, and their symptoms would just be right back, but we were able to get it under control again.
I think that it's important for people to understand that although this is alleviating their physical symptoms, it's not wiping out their memory
Oh,
of the
absolutely
event.
not. This is not eternal sunshine of the spotless mind, or
Yeah. It's enabling them to process it better.
And what we see happen consistently is a lot of times people do okay when they're in the thick of it, when they're in the fold, when they're with their group of people.
Right.
But as they get older, as they get other healthcare problems coming in line, as they leave the fold, I call it their demon containment unit gets weak, and they come out and wreak havoc. And then what do? They know how to make themselves temporarily feel better, and they choose those things again and again. So people use medical marijuana, fine. People use alcohol, not the most productive way of doing it, but they're looking to get rid of that horrible, that bad, tight feeling in their chest. They know that a couple drinks do it. And some of them, and this is actually Dakota Mayer said this great on a Joe Rogan episode, where he was like, I had this tight, bad feeling in my chest, and I didn't even know that was anxiety. Yeah. But he knew that drinking helped make it go away temporarily, at least.
And then the sad thing is that the self-medicating has not only a detrimental effect to the veteran, but also to the veteran's family. And so
actually the PTSD has a detrimental effect on both the veteran and the veteran's family. The self-medicating is exacerbating what is already a bad situation.
Yes, absolutely.
There's no happy ending for self-medicating. It doesn't make it better. It's just temporarily, how am I going to get through tonight? One thing I was going to say though, just to the audience, not anything, when people have PCL-5 scores in the 70s, I don't even ask if they're suicidal anymore. They are suicidal. They've all thought about taking their own lives, and because they're so anxious they can't stay there anymore. They can't stay on that X. They have to get off. And I've had people come to see me, and the only thing that they're scared of, they're not scared of the procedure. They're scared it won't work, because they don't know what else to do.
Yeah, and that's why I think it's so important for people to understand that this is available, because it's just phenomenal. And to be able to get an injection and not have to be taking all of these mind-numbing drugs that so many veterans are saying, I don't want to go see anybody. I don't want to talk to anybody. I'm just going to get a bunch of drugs. I'm just going to be numbed out. I'm not going to be able to function, and I don't want to live like that. And so they end up self-medicating, and it's just self-destructive all the way around. And I thought, well, people just have to know that this is available, because it's so immediate when it works. It's just phenomenal.
And to that end, it's part of my standard kind of intake when I'm talking to them. And I tell them, look, what you have is an untreated injury. You have an injury that happened. Everyone's got a break point. Everyone will face so much stress, and then they'll have a break point, because although we're designed to move smoothly between fight or flight and feed and breed, like the gazelle running for its life from a lion gives up the chase, goes back to grazing. That's how we're supposed to work. But we also have a negative bias, and that negative bias is that we remember bad things that can take our life, and we remember them perfectly. So if you and I are walking in the woods and a grizzly bear runs out and chases us, we don't just remember that a grizzly bear was there. We remember the sights, sounds, smells, feel of the air, and it's a memory without a timestamp. And people that don't understand PTSD don't understand that it's not a memory at all. It's not like they're having a flashback and they're remembering something. It's a now. That memory is no timestamp, and it's just as terrifying. It's everything full living color coming right at you. So what I tell people, look, this is an injury, it hasn't been treated. And I go, look, if you came into the emergency room and I held up an x-ray of your broken femur, and I looked at that and I said, well, you could have slipped and fell in front of Walmart. You could have fell 30 feet out of a helicopter. You have a broken femur. So we're just going to treat that injury. And I kind of let them know, hey, how you got there isn't important. You have a broken femur. And then I say, now I'm going to try to get you around to my optic of looking at it as an injury, because would you feel guilty because you couldn't just get over your broken femur? Of course not. Ludicrous. but they
Right.
all feel so guilty because they just can't pick themselves up by their bootstraps and move on. And
Yeah,
they
for
feel
sure.
guilty. I say, would you feel guilty because you can't run? Well, it's ludicrous. You can't run on a broken femur.
Mhm.
But they
Mhm.
all feel guilty because they're not the husband or wife or person of the year, because they have this terrible injury, and that gives them flash anger, that gives them feeling cut off from people, that not wanting to be around people. And so
Mhm.
they feel guilty about all these things. And I'm like, no, that guilt is holding you back. You have to see this
Right.
as an injury, and you have to, let's get it treated and let's get you moving on. And I'm not
Mhm.
sitting here saying that stellate ganglion block is an independent standalone treatment. I have never said that
Right.
in any of my
Right.
publications. But if you
Mhm.
have someone and they failed inpatient treatment and outpatient treatment, and they're on 1, 2, 3, 4 psychoactive drugs without improvement, and they're still at a PCL score that's very high,
Right.
why not try it? This is
Yeah.
extremely safe. It's a very safe procedure done by a skilled professional. It is, the relief can be profound and life-changing. And I have, if on my, actually on, like, if you look up health grades or vitals on me,
Mhm.
it just so happens that I treat a lot of folks with this, and you see
Mhm.
like story after story of these people who leave reviews that, like, this has changed my life. This is over and
Absolutely.
over and over. And so I'm like, hey, let's just consider that this might be
Abs-
useful to these people that are in the grip of a terrible illness. Let's get them out of it. And then my only limitation is when if they're doing well after a stellate ganglion block, my only, for their behavioral professionals is, please don't engage in a form of prolonged exposure or a form of exposure therapy, because it can just re-trigger them. If they're doing well, don't do
Right.
that. If before we do a block, or you want to try something like that, that's fine. But if they're doing well after a block, it's not the time to engage in some kind of prolonged exposure, because I see people come back to get another block because they
I can
re-trigger.
imagine. Yeah, absolutely. One veteran that I spoke with said that a friend of hers had had this. It was hugely effective. But in this person's case, they were still active duty, and they were very concerned that they were going to not be able to continue serving because they had had this. And I wonder, has that changed at all since the report has come out in 2019?
Actually, 100%.
Good,
That was the
good,
military maybe 10 years ago, but we've really gotten
good.
on board with addressing the stigma of PTSD, and addressing that,
Mhm.
hey, if you need help, well, look, we've been in combat now for decades. If you need help, get
Right.
help. This is a, it's not like they told you it was going to be when you were a young trooper. You don't come home and have, 2 fingers of single malt and get over it. It's not
Right.
that way. When you really do the job, when you do the job that your country asks you to do, um, it can take a toll that you are
Absolutely.
not prepared for, and let
Right.
us help you. And so I dealt in organizations where everyone had security clearances. We were able to treat people. Nobody lost their clearance. It was
That's good.
even pilots on flight status. We were able to treat them and get them back onto flight status.
Mhm.
So this thing is, and it used to be a huge thing in the Air Force pararescue men in particular.
This
The
was
Air
Air
Force was
Force.
very backwards in
Yeah.
their treatment of these people, but
Mhm.
that's changed. You can
That's
see
good to
and get
know.
treatment for that.
Okay. So
And
you
then
don't have to fear that you are going to lose your active status because you were getting treated this way. I would think it
Well,
would be
I
better
think it's something that you have to feel out in the person that you seek care from. I think that there's
right.
no question that behavioral health providers are on board with this. I
Good.
think
Yeah.
that people still have that that fear of being labeled as having PTSD still
Yeah.
exists, still
Yeah.
real. It's out
Yeah.
there. Our patients have that and deal with that. And some people,
Mhm.
like in police organizations, they're about 10 years behind the military. They're still like, hey,
Yeah.
go have a drink, go whatever, go cool off. They really don't acknowledge. They're very behind the military in that. I'm hoping to get them up to
Yeah.
speed, and I'm seeing high level like firefighters, police officers, EMS
Mhm.
providers. You look at their job and you don't know how they don't have it.
That's exactly right.
You
Yeah.
know,
I look at the
their
people.
day to day is crazy.
treating COVID right now that are on the front lines in the
I've
hospitals.
treated healthcare workers that work in ICUs with COVID patients.
I can
So
imagine.
yeah, and
Yeah.
it's very stressful for them. And they're in fear for their lives, they're in fear for their families' lives. So these are all situations where it's this anxiety that is relentless, is all around us, and it can result in post-traumatic stress illness.
Mm-hmm. What's so remarkable about this too is its efficacy, as you said, for survivors of childhood trauma, for those dealing, that have been damaged through sex trafficking and all different kinds of post-traumatic. The trauma can be any kind of trauma, and its impact of what the SGB is able to do is just enormous. And how available is it for civilians, for non-veterans, for first responders, for non-military? How are they able to access it for treatment?
Unfortunately, here's one thing that we're still dealing with is, unfortunately, I'll explain, or maybe fortunately, this is not covered by insurance for PTSD. I say fortunately or unfortunately because when I sit down and have a new person come in to get a stellate ganglion block, I end up spending 45 minutes of time talking to them about what's going to happen and informed consent, but also talking to them about the things around their injury and trying to give them awareness about the guilt, about treating it like an injury, about what's happened to them after they have it, that it was nothing I injected, that it was just, this is, they're feeling their absence of their anxiety and their follow-up plans. So I'm in private practice, to keep my clinic open and pay for my employees and my equipment and my square space, it's cold hard numbers of medicine, cost me about $750 to $800 an hour to keep my clinic open. So if I get a procedure and they say, yeah, we'll gladly pay for this, insurance will reimburse you $150. Well, all of a sudden, I cannot give that care and stay open for, I'll make it through the month or two.
Right.
So having a fair level of reimbursement that you have to have for a medical clinic is part of the reality, but this is available, and actually people can get on the internet, they can call anyone can get this done. If you feel like you have PTSD, even if you don't have a formal diagnosis, or if you have a formal diagnosis, you come in, we screen you with these survey questions and ask what's going on. We try to make it not prohibitive, and then what they do is they call, and after they're screened, we decide whether or not they'd be a good candidate for this. If they are, we can do it. I mean, we do it here in my office in Annapolis, and I know other providers.
And it's outpatient. It's an outpatient procedure.
It's an outpatient visit. It takes 45 minutes. You should have a driver to take you home.
Sure.
And that's it. They do very well with this, and then that's it. Then we just follow them up at 1 week and 1 month, and I think that's the important part. You have some people that are providing stellate ganglion blocks that aren't familiar with doing it for PTSD. They're not doing the follow-up. And if you don't do the follow-up, then you're not learning. And the worst thing is you're not really seeing how incredible and life-changing this is to people. So you don't have the chance to kind of get behind it as a treatment modality. Because if you're only spending 10 minutes and you come in and you do the block and you walk out and you don't have any aspect or element of the story. And not only that, that doesn't really work for the patient either, because it's actually what you have right there is a therapeutic window where you can give them awareness as to what's going on, not just do a drive-by injection or have them, sedated and not even know what's going on. So this is how this care is delivered matters. And there's, some people in the country doing it very well. I don't really have a formal network of these providers yet. We're here in Annapolis. There's a couple of people I trust across the country, but not a lot of people yet. But myself, and then I know in the spring, I'm going to have Colonel Jim Lynch, who's retiring. He's going to be joining me here. And we're both two of the top researchers in this. I'm in contact with Dr. Eugene Lipoff, another top researcher in the
Center.
field, and he's in Chicago. And we corroborate, we talk, and we want this to be available. Because I have to say, What you said before, having not heard of it, I felt like I've been lecturing this internationally for years now, for over 10 years, reporting on our research, talking to anybody that will listen.
Yeah.
And I tell people that I feel like in Greek mythology, there's a character, Cassandra, and
Yes.
she was fated. She disappointed Hera, and she fated her to always know the truth and speak the truth and never be believed. So we're sitting here saying, hey, we're seeing people get better. We don't have a dog in the fight. I'm an employee physician. I'm not trying to make money off of this. I'm saying, hey, we see this helping people. We would like this to be available as part of a treatment plan for their post-traumatic stress injury. We think this can really help. Like, no kidding, we've seen it change lives. And it feels honestly like a burden to me that, like, I thought this would be like packing a snowball at the top of a steep, snow-laden slope. And I just say, hey, see how well this is working? See these papers? And then it would just kind of take off and get away, but it never did. And we're still clawing it forward.
Is the resistance because it is so effective, so immediate, and it's threatening to long-term psychiatric pharmaceutical companies? Is that where the pushback is coming from? Because this is pretty phenomenal in terms of the impact it's going to have on them.
I have to say, for the longest time, I really said, no, but I do see there is resistance. I see people behavioral health professionals that I've published papers with, not referring people that were really, really ill to me, that they treated for a year and they got no better. And I'm like, we did this paper together. Why would you let them suffer like that? Let's see if these can help. And so I think that there is resistance by behavioral health. And what I would say to each and every one of them is, you're all welcome to come by my clinic any day to see how I treat patients, and to know that I don't want your patients. I'm a musculoskeletal and spine physician. I really like doing that work. I would love for this to kind of move forward, but we can help your patients, and I'll give them right back to you. I don't want to keep them. We'll help them. We'll get them out of it. But when we do this, there's still work to be done. I mean, we didn't take them all out, and giving them the coping mechanisms to deal with their life and giving them further awareness. This is just a part of a treatment plan, but it can be a very decisive, inflective point in their care.
Life-saving.
And that you are welcome to come by here. I will call you back and chat you up. We will figure out how to take care of your patients. And but what happens is, it's a confirmation bias issue. They know what they learned first, and that this is new, and that new things are, even if they have evidence, even if they just don't, it doesn't fit in their model, and they will be very dismissive, even of high quality evidence. They'll be dismissive. Say the evidence wasn't that high quality. Say it really wasn't that good. I know people in the VA system that have sent veterans out to have electric shock therapy, which is a destructive modality, doesn't have one paper on PTSD. They sent them out and they paid for their electric shock therapy rather than sending them out for a stellate ganglion block. Now, riddle me that. What is going on there? Well, electric shock therapy, they used to treat very serious depression. That was part of their confirmation bias. Their setup where they're like, hey, it's a modality, let's see if it works, rather than trying something safe, non-destructive, And immediate. I don't know if a single, death or a single, it's just not, this is not a destructive therapy. We reset the system and it comes back. Their demon containment unit can now hold on to the demons. They feel relaxed and calm. And the first part of treatment for PTSD is to reduce that anxiety and sympathetic tone. We can help with that. I want to work with them.
Yeah, I definitely want to help get the word out, because I think it's incredible. And I wanted to ask a question. Let's say somebody has trauma, veteran, non-veteran, or civilian, non-veteran, veteran. What if they are taking medication and they are getting psychiatric care, and they suffer from PTSD, trauma, anxiety, depression, and they are on certain drugs to help them with that? do they have to wean themselves off of those drugs before they're able to get?
Absolutely not. In fact,
Okay.
what I want is I want them to maintain 100% the status quo. As far as
Okay.
medications, I don't want to perturbate the system. And then if they come in, and then if they're doing a lot better, usually what I do is I give them a target. I go, the first target is to wean under control, wean slowly,
Right.
wean any
Titrate.
benzos that you're on. So any benzodiazepine-based drugs, they're stopping you from getting restorative deep sleep. And so we have to get rid of those to lead to true healing. They feel good, they work right away, but they take away that deep sleep. They hit the same GABA receptors as alcohol. So this is something where that's my first target for wean if they're improving. And then the other drugs, if they're really doing well and they can be slowly weaned, great, then they should be slowly weaned under control of the prescriber that put them on them is the perfect sense of that.
So they'll feel a sense of calm, but it's not a drug-related calm.
Absolutely not.
And the drugs that they're taking are not going to feel any different to their brain. Is that correct then? So that they aren't suddenly going to say, whoa, I'm feeling these drugs really differently in my system now because I have taken away this feeling of anxiety. Do you know what I'm saying?
Oh, they're working by different pathways, like the common class of drugs of the SSRIs. They're slow on, slow off. They're hitting a different system, and it's very reasonable if they're doing really well. They're basically their PCL5 scores normalize into the normal levels to slowly wean and see how that's tolerated. Like I said, the first target is always benzos with me, and then after that, it's just you have all the time in the world. You can take your time to wean them off these medications because it's not going to change the fundamental reset that happened. And I also don't feel that SSRIs are that detrimental to their recovery or to their sleep. So they can slowly be, if you don't need a drug, all medicines are poisons. And you hope that the effects are better than the adverse effects. So if you don't need them, you should be off of any medication. That's a reasonable statement. And so if they're really doing better and they can tolerate dropping down, maybe they can come off them altogether. I can tell you that many of my patients get off of all medications and are very proud of that. And not only that, then they don't feel damaged as soon as they don't have to take a pill to feel normal.
Yeah, that's fantastic because they really don't feel normal when they're taking the drugs. And I was speaking with a veteran about a week ago, and he said that he was just so zoned out. He had PTSD, and he was in the service and getting all of these drugs, trying to work it out. And he left the military because he could not, he said he just would lose time. He said, I can't do this job and be taking, my men and women need a leader. And I can't be that leader for them under these circumstances. And I said, that's like the definition of a true warrior. I said, you're giving up your whole career because you recognize that you're hurting the people that you want to lead. I said, that was really brave of you to do. And then he came home and almost killed himself because he could not get the help that he needed. And I'm thinking, oh my God, did somebody tell him about SGB? This is just phenomenal. And he said he was given, during that period of time, he was given drugs and he was on Klonopin and Ritalin and a lot of different things. And
it's so interesting that you just said that combination because I see a lot of these people on amphetamine analogs who, because they have a hard time concentrating because of their PTSD, so they're given these amphetamine analogs, and I'm like, you're amping their sympathetics. You're going 100% the wrong way on this. You're amping them with amphetamine analogs, and we're trying to calm them down, and not calm them down like drug them, like just make them normal.
Yes.
The baseline. And you can't do that on those drugs. And I see that combination a lot. And I wonder, like, are you really thinking this through, who's ever prescribing this? Because like, oh no, they have ADHD symptoms. I'm yeah, you're right. There's no way that those symptoms are coming from the checklist that we have for PTSD that they have. And so I see that a lot, and I think that they're just like throwing medication at a problem,
Right.
and it's not a very thoughtful application of it. And
No.
that's my opinion.
But what was terrifying is they said you have a choice now. You've got the two drugs that you're taking, so you can take one or the other. And so he said, well, I'll stay with the Ritalin because, he was active duty and he was trying to think straight. And they said, okay, you're off the Klonopin. And he said, wait, I can't just be off. And they said, you're off. And he said, I've been taking it for months
Klonopin's
and
nothing.
months.
We give it for, they give it to nightmares. It's an alpha 1 blocker. It's like nothing. It's hardly even, it has a secondary effect of calming, but it's
He
a very
said
benign
once,
medication, as long as your blood pressure is fine.
He said once it was taken away from him, he really just lost it. He really lost it. So I don't know if there were other things that were on top of it, but when he was at the point where he wanted to kill himself, he tried to get an appointment to come in. He said, I cannot go through another night like I just had. And they put him on hold and said, well, we can see you in 2 days. And I thought about this poor guy who had left the military, basically told that he was broken and worthless when he's trying to do the right thing. And now, he's told, well, we can't help you until 2 days from now. And fortunately, a friend of his, somebody that he'd been in the service with, called him and talked to him for about 6 hours and really helped him. And they ended up starting this app called Objective Zero, where you can contact other peers all over the country, all over the world. It's a free app to be able to reach people that are going through what you're going through and give you the help you need at any time of day or night, and anonymously. And I thought, wow, that was a horrible experience you went through, but an incredible outcome. So we are trying through the Veteran Summit as much as possible to let veterans know that there are a lot of things out there. They don't have to be left or abandoned. And especially something like this, which is so effective, it's outpatient, it's immediate, and the percentages are so high. I know you're familiar, I believe, with Doc Springer, who's also someone that I'm going to interview, and she's very, very impressed with what this has done. And
Shauna's a very impressive woman altogether.
She certainly is. And she said that her patients, all of them responded to this. So it's very exciting. And I would like to hopefully let more veterans know that it's there. And one of the reasons particularly that I wanted to interview you is because you are a retired SEAL. And I think that there is such a resistance to, oh, nobody knows what I'm going through. And I'm thinking, well, this doctor does know what you're going
I have to tell you, it's a bit of a superpower to be able to sit down and immediately relate to these folks in the military. And they know that I'm like, I get it,
Absolutely.
And it helps a lot. It removes a lot of the barriers. And there's just a rapport there that's hard to develop. You're coming in for a one-time injection, and you don't know this person and they don't know you.
Yeah.
And I see physicians who do this, who will ask all kinds of intrusive questions about the nature of the trauma. And I'm like, no, stop. That is not what you're not about pulling off that scab right now. You're about saying, hey, this is an injury. Let's treat it, move forward. And I can talk to them like a soldier.
Immediately. Yeah, you immediately have that trust because they know you know. And that's one of the biggest criticisms is I don't want to go see anybody. They have no idea what I'm dealing with, And so I think that this is...
I have enough of an idea that I don't ask,
That's exactly right. I don't need to know that because I already know. Yeah. And I think that also brings a tremendous amount of weight to what you're saying. And I'm so grateful that you were able to speak to this because I think that they will automatically want to listen to what you have to say without that wall that's up.
It's legitimate. I'm not.
Sure.
I want to help them. I feel that our country owes them that help too. I feel they did the job that we asked them to do, and we broke them. in the course of that duty, and we owe them effective treatments. And if I'm not saying as soon as I find out something better than stellate ganglion block is out there, I will send people for that if I don't know how to do it. It's about, hey, our country owes this to these very few percent of the population that are putting their lives on the line for our country. And when we break them, we should do everything we can to restore them. And now I see families like where we always try to find sources of funding to treat veterans. I sometimes feel a little bit bad because it's not just veterans, right? It's, whether it's police, whether it's like, think of the child abuse victim. I mean, they didn't pick that. Like, why aren't, but at the end of the day, we're trying to help as many people as we can.
But the child abuse victim, you're saying, can be treated at your clinic.
Yes.
And that's just incredible.
Well, if it falls in the category of PTSD, and if you buy into the fact that part of that pathology sequelae is this stuck sympathetic nervous system, this constantly activated fight or flight nervous system. If you can get them a little bit of legroom for a little while and a little bit of awareness, it can lead to a lot of good.
I'm speaking tomorrow with a victims advocate for sexual assault victims in the military. And that number is just staggeringly high. And they are clearly suffering from PTSD. And we have no way of knowing how many suicides are linked to sexual assault.
Oh, well, this brings up a great question. The bigger question writ large is, why is it that there is no formal link in the medical literature between PTSD and suicide? That formal link doesn't exist. We treat it like it's a link, but when I went to try to really say, hey, okay, where is the studies that show that if you have PTSD, you're more likely to kill yourself from suicide? It seems intuitive because we see it happening. I've had people tell me, they sit down in front of me and they say, if this doesn't work, I'm going to kill myself. Pretty straightforward, right? I mean, it seems to be a link.
Yeah.
But, and usually if they're another fellow military member, I say, look, just give me the combination of your gear cage just in case it doesn't go how we think it's going to go. I try to put them at ease, like, hey, no pressure, right?
Right.
So, but yeah, you have to put them at ease. You have to get this, reset happening.
What do you do so in other words, as I was going to say to her, is if you have a sexual assault victim or survivor who has PTSD, this is a therapy that they can consider.
Absolutely.
And they need to know about it. So I want to make sure that I am telling
and what's so
this.
huge about it is, like, we talk about guilt from not getting over your PTSD. Sexual assault is like guilt in all caps, 64 font. I mean, they feel guilty, like I shouldn't have been there. Here they are, the victim, and it's so classic that they always feel guilt and shame.
Absolutely. Yeah.
And same with child sexual assault, that same shame.
Same thing.
And they can know in their brain that they're a victim, that it should have had nothing, what they were wearing or where they were or who they were talking to shouldn't have anything to do with them getting attacked. But somewhere there's this kernel in their body, this core that they just feel wrong. And you're like, you can't logically think your way through it. And I try to help them with that. But what I do is like, look, I'm not really going to get there, but let's reset this anxiety.
Yeah. What do you do, or is somebody who is suicidal eligible? I mean,
100%. Are you kidding me? These are people that,
let's say we don't know why they're suicidal. I mean, for instance, I'm thinking
from PTSD. This is a treatment for PTSD. There are lots of reasons to be suicidal. They could have, done a horrible thing and feel just crushingly guilty. They could be looking to try to escape a bad situation. There are lots of reasons why people choose to attempt or to end their life. And this is not a cure for all of them. I am 100% not saying that. If it's
Okay.
a result of their not being able to stand the anxiety and it's crushing them from their PTSD, this is something that we have seen success with. Nothing is 100% on this. And I'm not saying that this is either.
Well, I guess when I'm thinking of, since we've covered so many wonderful applications that it is good for, I'm thinking of teenagers. Teenagers that are killing themselves because of whether it's pressure from school, pressure from parents, shame, feeling bullied, being bullied. And I'm wondering, don't they fall, or couldn't they? I shouldn't say, don't they, but couldn't they be suffering from PTSD themselves as a result of being bullied?
Yes, absolutely. I don't want to say that this is, a fix for everything.
No.
And unfortunately, a lot of times teenagers kill themselves. It's a very spontaneous decision. This isn't like a well thought out thing.
Mm-hmm.
But if they're in this bad place, they should seek help. If the help that they're getting isn't addressing that, could stellate ganglion block be helpful for them? Yes. And I don't know. And once you're dead, it's over. So it's a risk reward analysis where the risk of a stellate ganglion block is very low, and it could have a profound effect on them. I haven't done. I'm a researcher, so I have to say I haven't done any research in suicide prevention. This is something that is completely hypothesis on my end. I try to really stick to what I know on this. You're kind of taking me out of my little comfort zone here, but do I think that that's reasonable? Yes. Do I think that it's would be harmful to try? No.
Well, that is really important, because if parents have tried everything else, I think that they need to at least be able to explore this, which is really, really important.
And this is the thing, though, that the patient has to want. I don't sedate people. There are some people that will sedate people. I don't sedate people. I'll sit down and talk with them, even if they're afraid of needles or whatever. I talk it through. I'm very calm. But it has to be something that they want to do. I say, I'll do something for you. I'll never do something to you. And because I think that element of control is actually important.
Yes. Well, you are extraordinary, Dr. Mulvaney. You really are. And I just cannot tell you how grateful I am to be able to speak to you. And if there is one sort of word of guidance or hope that you would give veterans that are going through this, that are sort of at the end of the line right now and saying, hey, I don't know what to do. You've just spent all this time telling them something really effective. Can you, as a retired SEAL, say, hey, listen, I've got this, let me let you know something. Let me give you some hope. Is there something?
Here's the message, and here's really my big value added, is when they come here, I let them know, hey, you're not on your own. Are you kidding me? This is really common. I've treated SEAL teams where I've treated 30% or more of the members. Like, if you're in and you're doing the business for your country. And then the other thing is that when I just want to disclose this right away, that I've had multiple tours in Iraq and Syria and other places. And I remember feeling like, people think like special operations.
Right.
And I remember I was in an emergency room in Baghdad. I was helping out in the emergency room, and I was debriding grit and rocks from the face of a military police officer who had just been blown up in an IED attack. Thankfully, he had his eye protection on, so he still had his vision. And I'm debriding him, and I'm talking to him. He's awake, he's alert. And at one point, he's like, oh, wait a minute. And he reaches into his BDU top, and he pulls out, or ACU, I'm dating myself by saying BDU, but he pulls in, he reaches into his fatigue top, and he's got the paperwork for a Purple Heart in there. And he's like, yeah, can you just fill out on the treating physician line? And I'm like, whoa, wait a minute. You guys go on patrol with this paperwork? And then at this point, his sergeant major had come over, and I'm like, Sergeant Major, all your guys are going on patrol? He's like, oh yeah. He goes, it's much easier if we get the treating physician to sign off on it. I'm like, how many of your guys have Purple Hearts? He's like, well, everyone's had a vehicle blown out from under them. So this is like normal. We're just trying to look out for them, make sure they get this this address. So, and I remember thinking, these guys would go out and do route clearance. We would travel at night, 55-mile max speed of our up armored Humvees under nods, going to some target to go get them. And they would go out at 10 miles an hour, route clearing, getting blown up. And so I think, what's special? These guys, this is like raw charge the machine gun nest bravery that these guys were showing every day.
Mm-hmm.
Special operations, no, they're regular troops, no less brave, no less deserving of care, no less deserving of our country's appreciation.
Yeah, that's so true. So true. And thank you for saying that. And one of the reasons I really wanted to do the summit is because I felt we had let them down so much, and that there was so much available to help them that they were not getting, and that they had turned away from the kind of care that was offered because it wasn't helping them. So
you've done a tremendous thing, and I just want to thank you, because really that's the one thing, is how do we get this information out there? And it's people like you that are putting this together. If there's anyone that hears me that would like me to speak on something, I'm happy to do it. I want this message to get out. This can help a lot of our brothers and sisters.
It absolutely can. And you are doing that in a way that they understand. And that is fantastic. And the proof's in the pudding. And it is definitely working. So thank you so much. I really, really appreciate this. And I will do everything I can to get this word out and to get them into your office.
My sincere thanks for this opportunity. Anytime. Thank you.
Thank you, Dr. Mulvaney. Take care.
Bye now.
Bye-bye.